Good morning. I'd like to thank everyone for coming for our clinical presentation for clinical professionalism. It's going to be Larry Maturin and myself. Larry has done a lot of work for ONU with doing some online courses and especially working with fundamentals with the first clinical experience. And I've done didactic and lab and also fundamentals clinical. Louder? Okay.
I'm sorry, I didn't catch your name.
Oh, I was getting to that. Okay, and I'm Davison, and I haven't gotten to that, but now you know who I am. Okay, so thanks everybody for coming. And when Joella asked us to do a presentation, Larry brought his ideas, and I brought my ideas of what's worked for us as far as clinical, and we put a PowerPoint together. So hopefully it'll be a little bit of a discussion, and we'll go from there. Thank you.
Oh, okay. Yeah, I didn't know. I want to make sure it was out of everyone's way. As Dawn had said, part of the impetus for doing this was to sort of standardize clinicals. That's the first thing, and then to sort of convey the ideas that really maximize the clinical experience for students. I usually like to start with sort of a setting the table. It's an article I encountered at a conference years ago. It's by Tanner, and it really talks about thinking like a nurse. And it really explores the ideas of clinical judgment instead of critical thinking, about the things a nurse, a patient brings to a situation in order to create the best possible outcomes. It also talks about ways to reason clinically. The nursing process is one, and there are others, but really the clinical experience is wedded to the idea that students actively engage in the nursing process. So that's really the point of their clinical time, is that they thoroughly understand the nursing process and their role in patient care with it. And then another key component of clinical is that students actually do the work, not only the nursing process, but give actual care, because it's through the doing of the work that they'll learn. All right, so again, basic skills that every student should leave clinical with. The core concept is that they improve. It starts at a very fundamental level, but through the clinical experience, they learn to develop clinical judgment appropriate to their level in school. The first step is assessment. So their ability to perform and document a clinical head-to-toe is foundational, and it's something that they do every week, every patient. And even for students I find that can't get that down correctly, before they move on to the next step of the nursing process, they're just given patients to do clinical head to toes on. And so the format for that is, and they know, they're given in sort of the orientation to clinicals, they're given a format, a document that says these are the data points that you must go in and collect, and then they learn that, they go in sort of open-handed, not with any template or anything, and just learn to rotely do a head-to-toe assessment and then walk out and document it template-free. And it's through that process that you're going to embed good practice with assessment. Next is the ability to formulate and prioritize the applicable nursing diagnosis. So as long as they're collecting all the appropriate subjective and objective data, the idea then is to learn to hone their diagnostic reasoning, because through proper diagnostic reasoning, then the appropriate interventions and optimal patient outcomes. The next step, again, the basic skill that every student should learn in clinical, the ability to set goals and plan outcomes. Now, this methodology is transferable, translatable. It doesn't matter if you're level 1, fundamentals, OB, psych. There's an assessment inherent in every area. There's diagnosis inherent in every area. And so these are just, it's a translatable methodology, and I think that's the utility of this. Continuing on, students should also learn to perform clinical skills. Again, fundamentals, there's a certain skill set and as they progress. And Dawn will talk more about this, that the skills that they get checked off on in lab, and then that's appropriate for their level to perform. But that's certainly something that they should do. Again, clinical needs to move from kind of the didactic, theoretical realm into the actual operational application realm. Another thing they need to do is practice safe medication delivery. And again, medication delivery translates to their appropriate level. So in the beginning, it's eye drops, ear drops, oral meds, and then it progresses from there. And that involves math, labs, the 3 checks, the 6 writes. So prior to any student giving medication for myself, they have to undergo kind of like a med assessment. So before they give drug aid, do they know the appropriate labs? Do they know signs and symptoms of problems beforehand? Do they know all the relevant information to safely deliver medication? Another skill that students should leave with is practice patient teaching. And I recommend that they do one topic every day. So I tell them that patient teaching is inherent in a nursing diagnosis. It's part of the interventions under the appropriate nursing diagnosis, what to teach. The medical diagnosis sometimes lends itself to what they could teach. And sometimes if they're stumped or they have a disengaged patient or a patient has other concerns, patient, what do you want to know? But to find a pertinent topic to teach related to why the patient's there, maybe upon discharge, what they need to know. Another skill that they leave, should learn in clinical and leave clinical with, and again, it seems like a lot, but it's just following the process, is the ability to give a handoff report. So they do practice SBAR, but as I teach them, SBAR is more transactional, right? If I just need to give you kind of a brief rundown summary, SBAR is pretty good. Otherwise, handoff report is more extensive. And again, it's a format that I give them, that I teach them, and it's another one of these things that they just need to rotely do over time, and it's through that repetition that we kind of build in that deliberate practice. And then that's the last point, oddly enough. Repetition is key to building deliberate practice. So we'll talk about post-conference here in a minute, but they give report, and then in post-conference, when it comes time to talk about their patient, the person they give report to gives report of their patient. So now they've engaged in both parts of the process. They've given it, and now they hear what they've given. And through that, they go, I probably should have said this. This was important, this wasn't. So I think both pieces work well together.
And that's just a picture of lab. The students have 6 weeks before they actually start in level 1. And they're practicing all their skills. Here you can see taking pulses on faculty members, on Ralph, and these are just some of our students in the lab. They have quite a bit of time to practice. And certain skills have to be performed in lab before they can be done in clinical. So we have a few shots of that. This is bed making. There's actually it looks like a burrito, but there's another student wrapped up in there. So they learn how to make beds, occupied and unoccupied in the lab.
So again, there are skills that a student should leave clinical with. And again, those skills really are married or wedded to the nursing process. All right, they must fundamentally understand that process and engage in it actively. The other thing I like to remind students, and it'll seem repetitive, but it's the purpose of their patient. And so the clinical methodology that I employ is not follow the nurse, follow the CNA. And again, anything discussed here is not prescriptive. It's mere suggestions to enhance what you do in clinical. But I like to assign students to patients. So that student has that patient, and they have specific goals they must get through the day with. All right. So the purpose of the student's patient, the patient provides an opportunity for the student to develop and refine clinical judgment. Makes sense. It's the fertile soil for the assessment, for diagnostic reasoning, for just engaging the nursing process. The patient provides an opportunity for the student to engage in the nursing process. And again, I often tell students, you have only one purpose of engaging with patients, and that is because you are in some part of the nursing process. Yes, it's conversational, yes, good morning, how are you, but you're assessing, you're getting evaluative data. If you're in the room doing something, it's some part of the process. The student's patient provides, and here's kind of a novel thought to students, not to us, but to students, the opportunity for the student to give actual nursing care. And that's why I think pulling away from follow the nurse, follow the CNA, allows the student to engage in the practice of nursing, incorporating the didactic training they're learning in class, which is another thing that Tanner really points out, that clinical, lab, and didactic should sort of all work together seamlessly. So this allows for that. But it also allows students to give actual nursing care. So when they develop those interventions, they actually go out and do those interventions, and then they can evaluate, because only through the process of actively doing can they understand that if the intervention was successful or not, and it really kind of like brings to life their evaluation. The patient is an opportunity for the student to teach. It gives, again, it moves it out of the theoretical to the concrete, to the operational. They're actually getting to teach a patient. And that's important because when they're delivering their teaching, the patient will interact back with them. So through that interaction, they can learn, again, what works, what doesn't, what patients responded to. Oh, I should have included this next time. Oh, I should have done that. There was an interesting experience now that I think about it. It doesn't really involve teaching, but a student went in and did her head-to-toe assessment, did a perfect job, and really actively involved the patient in the assessment. And then the patient looked at her and said, "What do you think?" And she was just lost. She just said, I did my assessment, and that was a perfect learning moment, because when we went out in the hall and we talked about it, I said, yeah, there's purpose to your assessment. It's not just doing it, but now you understand a question that could be asked. So in the future, you'll be prepared for that. So that was excellent. The student's patient provides an opportunity, given that they're prepared, for the student to deliver actual medication. The patient provides the student an opportunity to give and receive report. Again, both pieces. So I give report prior to the end of clinical to another student. I get their report, and then we go into post-conference. I give the report I got. So again, they can listen, they can hear, and it just refines. And the patient provides the clinical instructor, you, me, all of us gathered here today, an opportunity to provide clear guidelines and to set standards. We have to give students the leeway to learn their own way, to kind of learn how it works. But it's learning with enough like rope to do, but we provide the guidelines and set the standards and then hold them to it. I think they appreciate that, man. Oh, yes, some housekeeping items, thank you. I always like to let students know that report is required to perform any procedure on a patient. So if they have their patient, they've gotten report, they've collected all the data themselves. But if student B has never DC'd an IV, something very simple, that SBAR or some minimal report or what's going on with the patient, even prior to doing that. It comes along later, but no procedure, no medication passing, nothing occurs without the instructor physically present in the room with them, supporting them. Assessments required to pass medication, and that means any student passing medication has to get done that assessment, form their diagnostic reasoning, and set goals prior to medication passing. So yes, they're given that clear outline and expectations of what their day should look like, but it's not a time frame that elapses over the whole clinical day. They have to get it done prior to certain tasks. So in that way, you're able to say, here's the task, now let's teach you time management. So over time, it's layered to kind of give a complete picture. There again, no procedure or medication passing without the instructor physically present. And this does need to be clarified from time to time. I'm not sure where the disclarity is, but they say, oh, can I do it with the nurse? No, I have to be there. We can do it with the nurse. Oh, I've seen it before. Can I do it? No, we have to be there. So again, no procedure, medication passing. Boom. Another thing, never discharge a patient. So they can be there while discharge is going on. They can participate in the discharge process, but they can't, like the staff may say, oh, can you load them in a wheelchair? And no, unfortunately we can't. No discharging of a patient by a student. And then I always say, we always swim with a buddy, so we want a clinical with a buddy. So in the beginning of the clinical day, students are assigned a partner. Now that partner is, you need lift help, there's your partner. You need patient care help, there's your partner. You have a question before you come to the clinical instructor, problem solve with a peer. And then if you can't figure it out or you want clarification, come to the clinical instructor. Also, if we should have male nurse, female patient, buddies there to protect that situation. If we should have female nurse, male patient, if we should have, whatever the setup is, the clinical buddy is there to protect patient, to protect the other student, just to lend fidelity and integrity to the whole situation. So I think clinical with a buddy is a good rule.
Okay. All right. So how do we put it all together? As Larry mentioned, we've got the didactic part, the online learning, we've got labs, and we've got clinical. So how do we put it all together so that the students have an optimal outcome in their clinical experience? So by week 6, when students start clinical, they are prepared to do the following. They can do AIDED. They practice this in lab. They can do a mini mental exam. And just by even their first few words with their patient, they'll have already done a mini mental exam. Vital signs, they've all been validated on the 4 vital signs and pain management. A focused assessment. So they take a course in health assessment, which is a pretty comprehensive assessment. And they will do that. But we also teach them that sometimes when you've got just like 10 minutes in the morning and you've got 5 other patients, you need to kind of focus in on the focused assessment. What do you really need to know about that patient related to what's going on with them, their diagnosis? Room check for safety. This is a big one for mine. So we might go in the morning to look at a patient together and the oxygen is laying on the floor, the tube is on the floor, it's out of the nose, or the bed rails are down, or the bed is high, or trash, not trash, but there might be like a little trash can or something that has gotten moved during the middle of the night. So make sure you do a clean sweep of that room. And we do a safety scenario before they go into clinical where we have every safety issue you could possibly come up with. And what's wrong with this picture? And then they have to go and identify it. And then, of course, their clinical skills. So the clinical skills that need to be validated before they can practice them in clinical, and they're validated in lab, are vital signs and sterile fields, hand washing, sterile gloving, and and medications, PO meds, rectal meds, and eyes and ears. Other things like perineal care and bed bathing and dentures and things like that, they will practice in lab, but they validate it in clinical. So they do have time, they practice on each other. I've got a few more slides of that too. Practice in lab by students before clinical starts. And as Larry mentioned, students cannot perform designated skills in clinical unless they have been validated in lab. We ask them to do, when they practice, they have to do it twice in front of 2 different peers, so they have 2 peer sign-offs, and then their instructor if it's one of those designated labs. Please check the student's skill card before they perform skill and reach out to the lab instructor or lab coordinator if there are questions. So on the front, you got your handouts. If you want hard copies of all the forms, but the skills card is a harder stock of heavier paper and is usually a bright color. They need to keep that for all 4 semesters as they get their skills checked off. So I tell the students after you get them signed off, take a picture of it frequently or Xerox it just so you have a copy, because over 16 months sometimes that skills card can get lost. So there's a whole quota they need to fulfill 80% of skills, and that's all explained to the students. So they have a skills card. Many of them put it in a little plastic binder thing so that they can always keep it. Okay. Here's a picture of lab and shaving. So we do it on balloons, and the goal is not to pop the balloon. And I think about once a semester we have somebody pop a balloon. It's kind of fun. But they're practicing their skills. This becomes like their second home, lab does. And here they are, again, doing vital signs, temporal on faculty and each other, thermometer, practicing pulse, respiratory rate, things like that, blood pressures. So they get lots of time. Brushing each other's teeth. So we talk a little bit about that. Have you ever had somebody else brush your teeth other than the dentist in there working away? What's that like for someone? And, so they experience that. Okay, professionalism. Utilize professionalism points. So the first page of your handout has an example of professionalism points. And I have a copy of that slide too. So when they come to lab, they have to be in uniform with white shoes, a white lab coat with the ONU patch, their name badge. That's important, a name badge, so people know who they are and why they're there. No piercings, tattoos covered up, hair pulled up. They really do look professional. And I've had over and over again in clinical, people come up to me and say, your students are so professional. And I said, yes, they're ONU students. That's part of your checkoff in the morning is, are they professional? That means being prepared. Do they have their stethoscope? No, it's in the car, or no, I left it at home because whatever. So their stethoscope, a pen, a little journal, a pen light, things like that. Things that you as the clinical instructor have told them they will need. So that's all part of professionalism, being on time, being prepared. Hold students accountable to uniform consistency, being on time, and assignments turned in on time. We'll talk about that. Facilities notice this, and then give frequent feedback to the student regarding performance and skills. And there are 2 clinical evaluation tools we'll talk about also. So here's a group of students, and so they all have white shoes. They're all there's no clogs. There's nothing like that. And uniforms are consistent, name tags, stethoscopes. And hair is back. So it's a professional and diverse group of students. So that's great. I think it's a great picture of students. And here's another, this was in lab, this was Halloween a couple of years ago. They didn't quite get all their professionalism points, but we gave them a break that day. And so we actually had a lab where they could come dressed up for Halloween. I think this one's not too happy. She forgot her uniform that day. Okay, collaboration. So it's a lot of collaboration between the lab instructors, the didactic instructors, and the clinical instructors. So what they are studying in lab and didactic is what you try to facilitate in the clinical experience. So how does that happen? For level 1, it's me. I send a course syllabus to the clinical instructors as you don't have access to Canvas. So you can't put grades in. There's a different way to do that. But you don't have access to the forms. They need to be sent to you by whoever your coordinator, whoever is doing that for your particular level. And then coordinate patient assignments with lab activities and didactic material. So look at the course syllabus or send an email to me if you're level 1. What exactly are they working on? What would be a good patient? Ask the students, okay, you guys are doing respiratory. There's somebody with some unusual lung sounds. Let's all go down and listen to that. Ask the students, what are you studying? What do you want to know? What would help you? Because they go, oh, I've got a test, Well, okay, what can we do in clinical to help facilitate your learning? How can we tie it all in together? So send frequent emails and updates to clinical instructors, and please notify instructors and level coordinator if a student is struggling. So we've talked about this in the past. If there is a skill they cannot perform, if by the end of clinical they still can't take a blood pressure, that should have been addressed back in week 1 or week 2. But if that is happening, there's a VLC, Virtual Learning Center remediation form. So those are online, and you can then send one to the didactic instructor and the VLC coordinator, who is Cheryl Rickard. And also, I think we decided on sending it also to level coordinator and didactic. And that's a plan. They sign it. There's a plan for their remediation. And here we're collaborating. These are actually the judges for the Halloween contest, but there's Joella and Bryn. And so it's just collaborate, work together to facilitate the process. Okay, so something you can do, attend lab for a few hours to observe how your students are learning. So if this is your first time being an instructor, a clinical instructor for ONU, come to lab to see what they're doing. You'll get a chance to meet the students before I started doing lab, and when I was doing just clinical instruction, I would try to come in a little bit and meet some of them and say, hey, you're going to be seeing my face next week. This is what I look like. This is what we need to know. If not, introduce yourself before with an email. Students can be referred to lab to practice skill if not successfully completed. We talked about that. And there's also something called a group education project for level 1. So they need time to work on a group education project and also on a nursing care plan. So you need to provide time for that in clinical. The group education project is something that they do as a group, and one of the main purposes is to see if you can work in a group together. How well can you collaborate with your team, because that's part of nursing. And so that you identify an area that the staff could need some education on. So in level 1, it's often things like falls or gait belts or passing food trays or hand hygiene. And you're going to present a pamphlet and a PowerPoint to the staff, but you need to also do it not in a reprimanding way, like, oh, we saw you not wash your hands, but with evidence-based practice. You're going to teach the staff with your pamphlet and present that. And they really like to do this because it has made changes. In one facility, after they researched gait belts and said how cheap gait belts were compared to a fall in the extended care facility, the institution went out and bought more gait belts. And the director of nursing was especially pleased because that was something she had championed. But then when you get risk people involved in it, it's like, okay, and so students have made changes with their group education project. And then collaborate with the facility to ensure optimal learning experiences. You are the representative for ONU to the facility and the go-between. So stop by every week or a few weeks if the director of nursing, as you're leaving, and say, it went well today. How can we facilitate the process? Or I understand that the Illinois Department of Public Health is coming next week. What does that mean for us? Or OSHA's coming. Or the students are very interested in why you do it this way, because some of them are CNAs and they do it that way at their facility. So can you help us with that? So just collaborate with the people that you have the contact. And that also helps our clinical coordinator, also Dana Blanton, because then she can understand where we're at. You build the relationship, you are the go-between, you are the representative. Learning opportunities. So when I started, I just kind of, with everybody I talked to, what do you do here? And tell me about yourself. And see if there's a learning opportunity. Part of what I would do with post-conference is some in-servicing, if there was someone who really liked to do it. At one of the facilities, the director of therapy, all the physical therapy and occupational therapy, loves students. And she's young and she's vivacious and energetic, and the students loved her. The problem was we always did it right after lunch, and they're exhausted. They're getting up at 5 in the morning. But the wound nurse or wound doctor, you'd be surprised. I think students surprise themselves that, oh, I like wounds, when they actually go in there and start seeing it, and they would be the person you think would not like it. But infectious disease nurse, some of the sites have those, and with our KRAs out there and hospitals and healthcare organizations measuring KRAs and reimbursement based on those goals, it's an important thing. Renal dialysis. They can't actually help with it, but they could do vital signs. It's okay with the facility. They can talk to the patient. They can watch the process. A chaplain. I've had several chaplains that have been really good, not only in talking about spiritual care, but also in talking to the students about, if the students are open to it, what it's like being a student and how overwhelming it is. And all of a sudden, priorities have changed, and you're committed to this program, and it kind of turns your life upside down. And what can we do about that? Social worker, discharge planners, they have lots of good information to give. PT, OT, speech. In rehab, even if your patient isn't getting speech, go with another patient to see that. And then rounding with doctors, that's more in the hospital, not so much in the extended care facilities. But I did have, I think a gerontologist come and talk to us one time and about a particular patient. Director of nursing, if they're up for it, you just kind of have to see what that relationship is like and what the students are like. But sometimes there'll just be a real click with that. And activities director, that's a big part. And I think too, if you're working like on a PEDS unit in the upper levels, things like activities director can be important. Safety risk manager. This is, I think you find this in the hospital. This is really an interesting person if they'll talk to students. And we've used all these. And then an outcomes nurse. So the nurse that manages falls and has to report on that. What do they do when a fall happens? Do they have a fall huddle? Do they announce it over? How do they announce that? And what is the what's the process? When I had a clinical that was almost all paramedics, when a patient fell, all 5 or 6 of them got up to walk down to help out, and I said, no, you're not going. You're going to let the institution take care of this. You're a paramedic. You're a nursing student here. You're not a paramedic here. So, we'll let the nursing student that's never experienced had infections, IV infections, pressure ulcers, things like that. These are all the things that healthcare facilities are monitored on, their quality outcomes. Well, here's somebody you probably might not. Yeah. So when you be selective when you pick who you have come to talk students, but this person may have had some really, really interesting things to say about the nursing station and healthcare. I think if we could find that person again to talk to our students. All right, learning opportunities. So encourage the students to share with each other. The first day I have them, usually we try to go down to the cafeteria to get breakfast or something and go through a few forms and what to expect. So you'll have paramedics. They have a whole different outlook on it. And let them talk about it. You'll watch the transition, especially over the 4 semesters, and it's kind of interesting. I mean, I remember having one paramedic say to me at the end of first semester, this is a very humbling experience when I'm doing it here. And I said, yeah, you're providing care, intimate care to a patient. It's much different than out in the field. CNA experiences, they'll think they know all about it. And they do know a lot of stuff. But now they have to think like a nurse. Why am I bathing a patient? Not because I have to do 5 of them today, but because I'm doing a skin assessment. I'm checking range of motion. I'm checking mobility status. I'm doing a mini mental as I'm bathing them. I'm finding out about their family a little bit and whatever they want to talk about. Physician, healthcare workers in other countries, we have that. That's very, very interesting. This is how we do it, whatever their country of origin is from. But now they're assimilating into the American healthcare system. They've chosen to become a nurse in the U.S. So they've got incredible stories, and you can weave them in. Respiratory therapists, occasionally we'll have people that have some background in respiratory. One of my most interesting, too, was one of my students had a master's in kinesiology, and I had signed him as his first patient. I can't remember what the disease process was, but he was sitting down at the table talking to the 4 patients who were there at breakfast. And one of the ladies was in a Parkinson's study with Rush, and she had a dopamine pump. And he just started talking to her, and he actually asked, can I, work with her? And I said, sure. It was that connection. I mean, motor, sensory, neuron kind of stuff. He was all about that. And that clicked, because when I would take other students, she would ask me, how is he doing? I said, we graduated. We finished. So sometimes that initial contact might might really help them. Can be done informally at lunchtime or more formally in post-conference. Clinical opportunities. So this is more for in the hospital. So surgical areas. If they're there for Adult Health 1 or Health 2, pre-op, OR, PACU, day surgery. It's kind of nice if they can be walked through. But make sure that the whole process, it's facilitating their learning process. So it might mean a little bit of work. What's it like to be a pre-op nurse? What's it like to be a PACU nurse? GI lab, they can do vital signs. Cath lab, radiology areas, interventional radiology, whatever the hospital policy is. These are really nice areas like the OR, but oftentimes they're maxed out. We've already got students from another institution. So that's why it's nice to develop that relationship. So when you come back as a clinical instructor, they go, oh yeah, we know you, we know your students. They're good students. They ask good questions and they're prepared. Emergency department, and then outpatient clinics. So what does a clinical day look like for level 1? First day, we often meet in the cafeteria and review any forms, contracts, and expectations. And I'll go through a few of the forms and then hard copies you can look at later. And so for level 1, like Larry mentioned, I try to pair students, a healthcare background with a non-healthcare background. So I go around, I tell them a little bit about myself, because they're curious. They want to know what they've gotten themselves into. And then for them, I say, you can tell me whatever you want to know, but I am curious about your healthcare background. If you've studied something else, what is it? And often it's some kind of biochemistry or psychology degree. But I've had graphic artists, and we had an accountant, who's now working, got a job, and that was a big switch to go from accounting to nursing school. And he was a little bit older too, so I would try to pair that and make that work. And it often does. And then after a few weeks, I say, okay, now you guys, you each have your own patient, but you can actually do things separate now. You know, you got your partner if you need to, but you can actually go into that patient room by yourself and talk to that patient. And then they work mainly with clinical instructor, occasionally with an RN, maybe the wound and dressing changes if they're following a wound nurse, and a CNA. But as Larry mentioned, it's the nursing process. They actually need to feel like they're doing nursing care for a reason and tying together didactic, lab, and clinical. Here's my assessment. I tell them it's putting the pieces of the puzzle together. You're reviewing the chart. You're doing the assessment to find out what's going on with their systems. So when the patient says to you, what's up, how I'm doing, you can say, well, according to your chart, your lungs sound better to me. I wasn't here last week, but you sound better. You look, according to the chart. They need to know about their drugs. They need to know all those pieces of the puzzle to give optimal patient care. And they really do have a good feeling when the light goes on. It's like, oh, do you think this happened because of this? Yeah, I think so. But then I take it down another rabbit trail. But what about rabbit hole? What about if this had happened? If you had seen this in your patient, what would that mean? Well, that might mean something else. Yeah. But what did it show for your patient? Okay, so here they are. This is on a mannequin, lab again. This is one of our paramedics. And he was just a pleasure to have. Just kind of look at me and go, no, how does this work? Never done this one before. Oral care. And doing dentures. So instead of intubating patients, he's learning how to do denture care. And then again, our mannequins in the back. Clinical day. Instruct students that first-time patient ambulates. There must be 2 students or a healthcare worker and a gate belt. Okay, so they go in there. Well, it's kind of interesting. So the first day of clinical, they kind of show up and get report. And then, they kind of go in their partners, and then they'll come back and they'll say, Prof. Davison, I knocked on the door and nothing happened. I said, okay. I said, go back. They said, I didn't know what to do. I said, well, maybe go in the room, knock on the door, and if there's... So they come back, knocked on the door, I went in, they're sleeping, what do I do? I said, you wake them up. Oh. It's like, yeah, because they've got physical therapy, it's breakfast. They've, and I, the day before, would go over and meet the students and say, the students in purple are coming back, be ready for us. You'll have a student tomorrow, and they'll be in purple, and most, if I've been to that site before, they're, oh yeah, those students are coming back, they're so nice. And they've made differences. One of our students, the patient had physical therapy like at 7:30 or 8 in the morning and did not get pain meds. So she worked with the nurse. Even though she wasn't passing pain meds, we talked about it, and I said, how can we make this, what can we do to facilitate this so this patient can do her physical therapy? Because she would just go and cry. So she talked with the nurse, and her pain meds were scheduled to be given on the night shift earlier. And I don't know how come that hadn't been thought of before, but she was so grateful when she left for the students who spent the day learning about her and going, what's wrong with this picture? Well, you can't expect somebody to be able to do physical therapy if they're in pain, so we just need to bump their pain meds up, get her up a little bit earlier. So that helped. So I teach them use a gait belt, until you know that patient. And oftentimes what they might tell you, oh, that patient can get up with one person, when actually it takes 2 people and you don't know that patient. So I always do that. And then they can do vital signs, bathing, AM care, feeding, pass trace, range of motion, complete assessments, ambulate and transport patients, go with them for tests, OP, OT, PT, speech, pass meds, and engage patient in conversation and activities. This is a big part because you're learning what it's like to actually touch a patient. When you're listening to those lung sounds, you've not done this before. Can I do that? Am I allowed? Yeah, you are. Okay. Practice it so you start to feel comfortable with it. You've practiced on each other, but a 25-year-old body is a lot different than an 85-year-old body. Or a 10-month-old body when you get into peds. Lots of difference. So engaging them, learn about them. So this is an education project, and I really, really like this. So that I talked about it earlier. So what they identified, this group of students, was that some of the patients were depressed and just would not leave their rooms. They're in rehab, they've been in the hospital for their surgery or whatever, and now they're waiting to go home. They don't want to be there. But what do they do all day long between their therapies? So they decided, they talked about depression and made a great little pamphlet, and then they went out and bought this and just developed activity and game cart. And it has puzzles, it has books, it has things like that, cards. And when they showed it to me, I said, oh, make sure you've got I mean, this is an Olivet. Make sure you guys get the credit for it. So there's their pamphlet. They all have to research an article to show evidence-based practice and put their name on it. So it helps them identify a need. It also teaches them how to collaborate. Because as nurses, you don't get a choice with who you work with. Just like you didn't get a choice with who you put in your clinical group. But figure out how to make it work. So big smiles, and here she is playing checkers with one of the patients from her cards. And a cup of coffee. I just think that's a great picture. Yeah. She saw a need. They saw a need in it. Journals and written work. So the journals, there's 5 of them that are due. And it's done almost in like a mini care plan. But one of the things, there's a rubric that we have, and it'll be sent to you because you can't get it out of Canvas. There is a day when I have, right before they start clinicals, during lab, when I go through every form that they're going to need, so that, and tell them how they're going to be graded and what they're supposed to be like, and how what they're doing, what they're for, and why they need to know about them. So instructors can come and sit in on that if they want to. It's usually a Monday or Friday, right before week 6. But part of it was because people were doing things differently. So now if you have one person explaining it to the students, that's helpful. So again, you have copies of all those forms. But utilize a rubric for grading. Reinforce APA style starting with level 1. Prof. Ritchie gives a APA workshop during level 1 during the first 6 weeks. And when they get up to level 4, they don't know how to write a journal or don't know how to use APA or have trouble with sentence structure. That shouldn't be. We need to start reinforcing APA on level 1. If they have any issues with, if English is not their primary language, there are helps that ONU has. There are references. Have them get in contact. Students and clinical instructors, we recommend they submit work electronically. With some of these things, after the instructor grades it and sends it back, then it needs to be uploaded into Canvas. Because instructors cannot upload into Canvas, students can, or the didactic instructor. So we work all that out. And the nursing care plan, we do a group care plan together before they go into clinical. But then they actually pick a patient and do a pretty comprehensive nursing care plan. So they need time. So in level 1, in the rehab facilities, they don't really have computer access because the charting is still cumbersome, kind of like the charts that we remember from decades ago. That's what they have to look through. So you as the instructor need to know how to find that information. So you have to familiarize yourself. Where does this facility keep their lab records? Where's their H&P? Because that can be helpful for their student. How about DNR? That's something that should probably be addressed with every patient. Their face sheet, maybe things you might need to know for demographics for the care plan. And then also for the group education, if they identified lack of gait belts, they would need time to work on that. You have 8 hours a day for 8 weeks, so it's 64 hours. So, okay, clinical checklist, we talked about that. That's what they look like. The skills card, we talked, that's usually a bright orange or green, or every semester it's a different color. They need to bring their skills card to every clinical. So before you let them pass the med, besides them knowing about the med, knowing about the patient, that has been checked off. And they can only pass with the clinical instructor what they have been checked off on appropriate for their level. Journal requirements with a rubric. And then clinical evaluation tools, there's a weekly one or a final. So the weekly one is just kind of a snapshot of what they did that week. And there's a choice of like satisfactory or outstanding. And it's the nursing assessment. It's assessment, diagnosis, interventions, evaluation. So is their journal. So is their care plan. So I say to them, do you see a trend here? You're being graded on how do you know the nursing process. Are you assimilating it? Are you bringing it all together? So they're weekly ones. And then there's a not observed, because there might be a skill you don't observe yet, and then needs improvement. So if there's a needs improvement, there needs to be some remediation tool or action plan. Like they can't do a blood pressure, and so they would need to go back to lab. So you need to have some remediation tool for that, for a needs improvement. They shouldn't be getting to the last week of clinical and getting and needs improvement, because it's like, well, we didn't do our work. We needed to address that issue back at the beginning. Okay, so here is an example of what you would want to assess every 8 weeks. This is what we use in lab. You can do it however you want to. But what I ask that you send me is, they have a total of either 0 or 15. So they either did all this or they didn't. They came prepared or they didn't. You send this to me weekly or every other week along with the journal grades once you start doing journal grades. And there's someone, this is back to our Halloween again. So this is what they shouldn't look like for clinical. But she's one of our graduates and she is now working at Palos. I just got an email from her. So sometimes we bring a little lightness into the lab. This is the journal rubric for a total of 12 points. I don't know how to bring it down. But anyway, so what I do in post-conference is their first few, when we have to start doing the journals, their first few post-conferences. Okay, so every one of you tell me about an abnormal finding that you found on your patient. And most often it's related to skin breakdown or maybe some kind of incontinence or maybe a swallow issue or something like that. So we'll all talk about it. And then we'll talk about, okay, so in your head, try to formulate a nursing diagnosis. And they'll go around and say, well, maybe it would sound like this. So we kind of have a plan going for them so their journal doesn't seem overwhelming. Because a journal's worth 12, and the first 8 points are up here. Abnormal finding, prior to diagnosis, and on it goes. And then a goal, then we'll talk about a goal. And then there's also a place for a safety concern. So we'll kind of go around and say, so what's your safety concern? Well, I saw a patient almost fall, okay? Or I saw something on the, there was something on the floor. Or the big thing was, well, I came in and they're supposed to be on oxygen, but the tank is empty. That's a safety concern. And then did you report that to somebody? And then down here, are you using the APA? Okay. So that's the rubric. That's what gets sent back. And then the students upload it. And this is an example of the weekly clinical. So assessment, diagnosis, plan, interventions, and then these are their 8 weeks. And then it's something that is signed by both of you at the end, and then uploaded. So something else I tell them to bring is a blank nursing care plan. Either bring that or bring their computer when they start getting information, because we can't copy forms and send out to them. So it's they've got all these in Canvas, and I show that all to them before they ever get started. This is how you can access this. So a blank nursing care plan, group education project, student meeting form, remediation referral, and then usual incident. So the student meeting form would be if you had to have a meeting about them for something. Maybe it was about being tardy or maybe not showing up, and check the handbook for what that is about. So there's a form for that, and you both need to sign it. It's kept in their file. Remediation referral, that would be if there's a skill that they had signed off on and performed but still weren't able to do it. And then unusual incident. So I've had that happen once when one of my students fainted, and that's something that needs to be put in their file. And send all these to the level coordinator and Joella, and the didactic instructor. So those 3 people. Post-conference, Larry talked about doing math, cardiac rhythms, medications. Oh yeah, that's Larry's. Okay.
Yeah. Before we talk about post-conference, I want to elaborate on 2 things Dawn said. First thing is feedback. Second thing is clinical opportunities. So feedback. Feedback is very important, and feedback occurs along the lines of the weekly journals, the weekly eval, or the 5 journals, the weekly eval, and the final evaluation. And I meet with each student every clinical day, and we touch those different points, except the final one, obviously. But there's always opportunity for learning. And one thing I find is one section of the journal, the ONU distinctive. They'll write things like lifelong learner or, just basic stuff. And I say, you can learn that in any nursing program. What is being an ONU distinctive? How does it inform and transform the care that you give? So I think even no matter how small or how insignificant a part of a journal is, it can always be ground for thinking. Feedback. Since they're working the nursing process throughout the day, I give them time. Go collect the subjective data. Go get a report. Go do your patient. Get back with me. Then I review the assessment they did. Then I say, what's your clinical thoughts? What are you going to do? How often are you going to evaluate? So they say, I'll reevaluate at the 2-hour period. Good. At the end of the 2-hour period, bring it all back, and then we'll see, is your evaluation comprehensive? have you covered all the data points? So feedback continuously throughout the day with each part of the process, with their journals, with the weekly eval. Okay. Clinical opportunities. This is interesting too, especially for beginning students. They're interested in learning everything and just seeing, and clinical opportunities, I let them go and see what they do. A lot of them go and observe, but then when they come back and give feedback, oh, I had a great time, this. Fantastic. Did you assess anyone? Do you have any diagnostic reasoning related to, in the pre-op area, what are some diagnoses? In the intraoperative area, how are those diagnoses changing for the same patient? In the postoperative area, do you have any diagnostic reasoning that's necessarily different because they're in a postoperative stage? What assessment did you perform? So again, the key, the thing to drive home is nursing process, no matter where you're at. All right, so post-conference. I usually start, I like to use post-conference to really sort of tie it all together. So I usually start post-conference with, and you can use it for any level, math. So I'll just throw out a math, 5, 10 questions. All right, just work them out amongst yourself, and then we'll regroup. And you can progress that however, the level of difficulty that you'd like. And then if they've learned cardiac interpretation, I give them cardiac rhythms. So they'll walk in and there's 4 rhythms. Let's talk about it. And then eventually, if after 1 or 2 times of just presenting rhythms, don't forget to print your rhythms on your patients. That's part of the subjective and objective data to be collected in the morning. And it's part of the re-eval data. What's their rhythm now at the forearm mark? Bring it in, we'll look at those. So it gives them a chance to constantly reinforce just basic skills. Then usually there's weekly presentations. So I have pretty set ones like what does Perla mean, and when you put your pen light in someone's eye, what are some physiologic, what are some medicinal causes of dilation, constriction, why are they sluggish, that sort of thing. So I usually keep it pretty clinically based, but then they may go, oh, I saw a BiPAP. I have no idea what that is. Well, excellent. Tell us about it. How does it help patients? What does it do? What's nursing care related to? What are some of the settings? So, and then they'll report back on that next week. So that's good. The third part is the nursing diagnosis. So that report they gave, they're going to hear back from another student, and then the bulk of post-conference, at least mine, are spent. What diagnostic reasoning did you reach based on the data that you've collected and the report that you gave off? So that is to say, not only can the person that's getting your patient understand what the patient looks like, understands how the patient's been trending, but understands too the care that you've been given and hopefully can continue that continuum of care. So a lot of post-conference as a group is spent on that diagnostic reasoning. So again, you may have enjoyed your patient and your patient likes the color blue, and it's all important information, but it doesn't lend to why you gave the care you gave. So that's really the focus of post-conference after our presentations and our rhythms. And then yes, Dawn has touched on the journals, how you can use the journal information to inform your post-conference and to add to it. Okay.
Yeah, and then you can also do skills card sign off and clinical evaluation tools, as Larry mentioned. Okay, let's see what's next.
Oh, good. Oh, there's just some other in-service ideas. Like Dawn mentioned, you can bring in ancillary people to discuss pulse, DNR forms, the quality assurance people to talk about falls, Braden scale, or you can have students investigate those issues themselves. In the fundamentals, we are in long-term care, sort of like these acute care rehab facilities. And so having students understand what a DNR, what a pulse, what a living will, what durable power of attorney is, and how that has interplayed in that environment in particular is important. So again, bring people in, discuss the forms, or have students investigate and deliver that content.
You want to do the wrap up?
No.
That was mine.
Yeah.
All right. So encourage students to let instructor know what interests they may have related to their patients. And Larry, I love his approach of, okay, you go out and find about it. You want to know about BiPAP? Okay, for next week you need to tell us. Well, we haven't done respiratory yet. That's okay. You can still learn. because assessment is all about is inclusive. Utilize as many resources as available, provide time and clinical for students to look at the charts, keep students updated on their progress. It should not come as a surprise to them if they need an improvement in an area. Talked about that. Okay. It should be something that's been addressed already. They may only perform skills they have learned and validated, and remind students it is a privilege for them to be at the healthcare facility where they are learning. And they will often reflect back on their patient care experiences in clinical. I think every single one of us can probably have some memory of our first clinical and what it was like, and how we thought we had probably like almost killed a patient, but no, we hadn't. You know, we were working through it, we were learning. So it is a privilege for them to be able to serve, and that's what nursing is. Nursing is part of their life journey, and their life journey becomes part of their nursing journey. Let's see what else. And they're wrapping it up. There they are. They're all wrapped up. So this is, I'm not sure which PPE, but which group this was. Do you know what group? You can probably identify it. I think they are all now level 4. We're done, maybe. That's one from a couple semesters ago.
It's hard to tell with the masks.
Yeah, it's hard to tell with the mask. Yeah. All right. Any questions on that?
Oh, thank you.
Thank you very much. Appreciate it.